Now, moving on to our section, that is the carpal injuries. We'll be discussing clinical assessment, what is the role of imaging, how to get different x-rays and what type of x-rays are needed to review different type of injuries, what is the role of arthroscopy in assessing the amount of ligamentous injuries and MRI, and then we will be briefly discussing the principles of management of the carpal injuries. Fractures and dislocations of the carpal bone are usually common. They vary greatly in type and severity. Sometimes entire carpus is involved, entire row is involved, or sometimes only one bone is involved. Commonest carpal injuries include, which may include self-limiting sprains of joints and capsules and trochleus ligament. More serious unstable tears of the joint capsules and trochleus ligament may be present as well. There may be fractures of the carpal bones such as scaphoid and lunate, and most commonly it is the scaphoid. There may be isolated ligamentous complex injuries such as triradiate fibrocartilage complex injuries. There may be dislocations of lunate or perilunar dislocations. So that is the broad spectrum of the disease injuries which can occur with the wrist joint. Usually the most common mechanism is following a fall on an extended wrist. That is, on an outstretched hand, the patient complains of pain in the wrist and maybe swelling or deformity of the muscle may be present as well. Tenderness usually has to be localized. Sometimes if it's a radially deviated injury, then most likely the scaphoid and scapholunate ligament disruption would occur. If the pain is around in the center of the carpus, most likely it's going to be lunate. And if it's ulnar deviated wrist resulting in a fall, that would probably rupture the TFCC ligaments and glenotrochlear area, which may lead to ulnar sided wrist pain. Now coming to the clinical assessment, how to assess what is wrong with the patient. For scaphoid fractures, usually falling tests should be performed. When we are most common at the time is injury, most common is the scaphoid injury. First and foremost is the tenderness in the anatomical snuff box. If there is a tenderness, probably there is a fracture of the scaphoid. Then pain on pushing the scaphoid tubercle backward, which is more specific. This is actually a part of a Watson test in which the wrist is slightly ulnar deviated and scaphoid is pushed from the volar side towards the dorsal side, and then the wrist is moved from ulnar deviation towards the dorsal, from ulnar to the radial deviation. Once that is done, usually this results in a pain over the scaphoid region. Or it could be pain on the axial loading of the thumb, because as it articulates with the radioscaphoid fossa in the first metacarpal joint, this can be painful as well. Another option is the pain on the passive ulnar deviation. Simple ulnar deviation can be painful because it locks the radioscaphoid fossa with the scaphoid, and if there is a fracture, that will be painful. Now coming to the tenderness. Scapholunate ligament injury or scaphoid fracture, usually just beyond the listus tubercle, this is where the most tenderness is. For lunar dislocation, mostly it's around the middle of the wrist. For triquetral, as it lies towards the ulnar side, so most likely it's the ulnar sided pain. For Hammad fractures, usually the pain is around in the palm of the area, in the just at the base of the hypothenar eminence. For TFCC, which is purely ligamentous injury, this is usually on the dorsum of the ulnocarpal joint. So imaging, we have to, whenever in orthopedics we get a type of injury, first and foremost are always the x-rays. Do we have to get a P view or lateral view, and what are the different views we can get is usually the key to diagnosis. The best rule is the 3 golden rules in x-rays. Accept only high quality films. If you are not sure, get another film. Usually, ideally nowadays, it's always digitalized x-ray, so it's very high quality. Early MRI reduces uncertainty and streamlines care. The important point is sometimes the injury is so subtle that there's undisplaced fracture or there is no fracture at all. There is just isolated ligamentous injury. Now that injury will not be picked up on x-rays. Bones will appear normal, but this would later on produce carpal instability. So for that reason, if we are suspecting there's a lot of tenderness and there's some kind of ligamentous disruption, probably, and on x-ray there's no fracture which can be seen, is probably we'll have to move towards MRI so that we can pick up the ligamentous disruptions early. And if initial x-rays are normal, for example, this was an undisplaced or hairline fracture of the scaphoid of the waist, and you're probably not sure whether there is or there is not, one option is to go for MRI, or you apply a splint Immobilize the wrist and ask the patient to return back in 2 weeks time and get another x-ray. If there was a fracture, that would by that time would have be clearly visible on the x-rays. Now coming to the other, what type of imagery is required. If MRI is not available, we can go for, as I told you, repeat x-rays at 2 weeks time. Usually the 4 standard views are done to obtain the mainly carpal bone injuries around the wrist joint. The most important is PA view with ulnar deviation. This is actually done to check for the scaphoid fracture. Other is lateral view. Why we do need a lateral view is just to check for neonate and perineal dislocations. Other options could be semi-pronated oblique views, just to see whether there is subtle subluxation of one bone over the another or not, or semi-supinated oblique views to see whether there is volar subluxation or dorsal subluxation of carpal bones relative to each other or not. On AP view, we have to note the shape of the carpus, look for abnormal large gaps because that would indicate a ligamentous disruption. Scaphoid may be fractured. Scaphoid sometimes with an inner circular density. This is called a circular ring sign because there is a tubercle in the dorsal side of the scaphoid. Once the dorsal side is displaced, this tubercle becomes prominent, showing a ring sign. Leonate is normally quadrilateral in shape, but in dislocation it usually becomes triangular. In the lateral X-ray, you have to see the traumatic instability linked carpal collapse, which may be in form of snack wrist or slack wrist, which is scapholaeonate advanced collapse, and scapholaeonotriquetral advanced collapse. Then it could be dorsal intercalated segmental instability, which is produced by snack wrist, or VC, volar intercalated instability, which is produced by leonotriquetral advanced collapse. This could be a flake fracture of the back of the carpal bones, which may be seen only on the lateral view. Usually it indicates the avulsion of the dorso-radiocarpal ligaments. Once this is the ligamentous disruption is suspected, despite there is no fracture and there is pain and tenderness, we usually go for an MRI to look for what are the different ligaments which have got injured. Now there are other special views as well. For example, this is called as carpal tunnel view. That is actually done only if the history and examination is such that it's most likely the hook of Hammad is suspected to have fractured. Then we probably go for carpal tunnel view. Motion studies can also be done, but they usually not done except for the research purposes. Clinically, they have less relevance. Then other option is we do not have an MRI, we can go for radioisotope scanning just to see whether that confirms usually whether there is a fracture present or not. The first and foremost is always the arthroscopy. In arthroscopy, this remains the gold standard to diagnose the ligamentous injuries. Why? Because we are able to see the ligaments being torn. The best way is it's not only diagnostic, it's also therapeutic. Then you can go in and repair these ligaments as well. So on wristscopy, the best way are the gold standard for demonstrating TFCC injuries and atrocious ligament tears if doubt from the imaging. So now coming to the principles of management. As you know, by this time you would have realized that there are bony fractures and then there are ligamentous disruptions. We have to deal with them in a different, and sometimes both may be present as well. So the initial, if it's purely wrist sprain, we have not diagnosed unless a more serious injury is there. If x-rays are normal, just immobilize the wrist in a splint for 2 weeks, 4 to 6 weeks, or at times 6 to 8 weeks. And usually that is enough. The ligaments heals and usually the pain subsides later on. If there is associated fracture or we are suspecting a gross ligamentous injury, then probably MRI scan is ideal. If MRI not available, then probably we will have to go for bone scan or radioisotope scanning. Arthroscopy is considered if there is uncertainty about the scapholaeonate injury. And why this is important? Because scapholaeonate ligamentous injury would produce a slack wrist, that is scapholaeonate advanced collapse, which is going to be highly problematic for the patient and may eventually lead to a lot of arthritis. Or leonotriquetral ligament injury, which can produce a snack wrist as well. Now, continuing with the principles of management, the aim is to treat as soon as possible to avoid unnecessary period of immobilization. If these tests are not readily available, patients should be re-examined repeatedly, but usually X-rays and MRI is almost always available throughout the world. Until the symptoms settle, a firm diagnosis is made. But the important point is you just cannot, if you're suspecting even the ligamentous injury, you just cannot just splint it and let it go. Because this ligamentous injury, if not properly healed, eventually can produce a lot of instability. In this section, we briefly discussed what are the different injuries which can happen around the carpal bones, around the wrist joints. The wrist joint is basically more made up of two rows of the carpal bones, where the scaphoid articulates with the radius, and leonate also articulates with the radius, but triquetrum and pisiform articulate with the ulna. Now there are three joints. One is the radioscaphoid joint, then is the radioleonate joint, then radioulnar joint, as well as ulnar triquetral joint. So these all different joints actually are connected each other with different form of ligaments. Now either there could be bony fractures, in form which is the most common, usually the scaphoid fracture. There could be leonate dislocations or perileonate dislocations. These are the bony injuries. Other form of injuries could be simply the ligamentous avulsion, such as scapholeonate ligamentous injury, leonotriquetral ligamentous injury producing DC and VC respectively, or there could be simply a TFCC injury as well. So we need to have a careful history or examination. We need to know where is the tenderness. First and foremost is to go for x-rays. If we still unable to diagnose, then MRI. If for example MRI is not available, then probably we have to go for bone scans. The ideal and gold standard for diagnosing as well as the treatment of these injuries is the arthroscopy. Thank you very much. Keep watching sqadia.com.